If we identify the anatomical variant of PAES, they go straight to the vascular surgeon. These patients do well from surgery, and it's probably dangerous not to manage them and manage them early because they're at an earlier risk of development of atherosclerosis and damage to that popliteal artery. If it's a functional type, unfortunately, surgery for these patients is not as successful and can have as high as a 30% failure rate. The reason being is that, a good vascular surgeon will want to cure the patient, but also remove the minimal amount of muscle that is necessary to fix the patient. So it can be a little bit hit and miss when the patient's asleep on the table to know how much of a myotomy to perform. The good thing about surgery is that it does offer a potential cure, but it's always awful when a patient wakes up and their condition's not fixed, having gone through the surgery. So this led myself and some colleagues to look at alternative interventions for functional popliteal artery entrapment syndrome. And what we came up with is Botox injections. So Botox has been around for a long time, predates the cosmetic guys by a long period. It's been used in managing cerebral palsy kids with spastic contractures. And effectively, it's a poison. It blocks the message at the neuromuscular junction and results in paralysis. So when the Botox is injected to the muscle, that muscle that's injected basically cannot work. And the length or duration of action of the Botox is for about 3 months. Now, while the muscle is paralyzed, it also shrinks and atrophies. So what we do with ultrasound is identify the muscles that are doing the occluding of the artery, and we inject Botox into those muscles. And typically that is into the medial head of gastrocnemius, and often additionally it's deep to a muscle called plantaris, which is a little more distal in the leg, but also seems to be involved in occluding of the popliteal artery. So we've done follow-up studies of these patients, and we found 1 in 5 at 12 months were effectively cured. We found 1 in 5 at 12 months said, I don't think that did much for me at all. And we found 3 in 5 patients at the 12-month follow-up had noticed some improvement in their symptoms, which was starting to wear off somewhat. So that makes sense when you understand that the duration of action of Botox is 3 months, that we're also inducing atrophy of the muscle. And in some people, that atrophy is enough to cure them. In some people, it's enough to help them, but there can be some resolution of symptoms over time. So those patients may benefit from a top-up Botox injection. So I've got one fellow who goes from being unable to run at all to, after the Botox, getting back to running ultra-endurance events. Now, the problem is over a year, 18 months, that muscle that we've paralysed and atrophied starts to hypertrophy again. So his symptoms can recur. And that person is quite happy with the knowledge that he gets good relief from the Botox. He understands that, every 12, 18 months he may need a top-up, but he's still happier to do that than a surgery that is not guaranteed to fix him. Now, that 1 in 5 of patients that didn't get much relief at all, probably now our feeling is that rather than saying the Botox didn't work, the feeling is that maybe they needed more Botox, that their variation of anatomy was so significant that just one lot of treatment was not enough to make a difference.